Good afternoon. Welcome to the Louisiana AAP RSV update. We are excited to have you all here to learn more about the latest and greatest in RSV for this year. We ask that as participants, you stay muted throughout the webinar. You're welcome to put questions in the chat as we go, and then at the end, we will have time for Q&A. A few housekeeping items. We have turned on closed captioning for this webinar. So to get that, look at the Zoom toolbar to turn on closed captioning in your view. You may need to click the 3 dots that say more at the bottom to see that closed captioning option. And then the Louisiana AAP is accredited by the Texas Medical Association to provide continuing medical education. This activity is accredited for 1 AMA PRA Category 1 credit. Here is the disclosure statement. Please feel free to peruse that as I send some more information into the chat for you. Okay, and as you come in, please share where you are based, whether that be in Louisiana or somewhere else. We'd love to hear where you're from. Okay. And I will pass it over to Ashley to do the introductions.
Fantastic. Thank you so much, Julia. And thank you everyone for joining us today. Just a reminder, use the chat feature. Julia and I will be monitoring that and making sure that the speakers are aware of what's being asked there. If there are any questions that remain at the end of today's training, we'll make sure to get those to the speakers and provide those responses when we send out the evaluation and other information following the training. So I just wanted to quickly tell you who's going to be talking to us today, and then we'll jump right into it. Our first speaker will be Dr. Joseph Bocchini. He is the Louisiana AAP president, and he's also an infectious disease specialist at Willis Nightingale System in Shreveport. From the Louisiana Department of Health Office of Public Health Immunization Program, joining us today will be Javon Davis. She's the operations manager for the Office of Public Health Immunization Program. Rafe Hewitt is a public health advisor at the Department of Health. Quan Lee is the data manager for the OPH's immunization program, and Adrian Mercadel is the vaccine procurement and distribution manager for the immunization program. So I will go ahead and turn it over to Dr. Bocchini and to get us started.
All right. Thank you, Ashley. Can you see my slides okay? Okay. All right. Well, welcome, everyone. Good afternoon. This obviously is a really important subject. We've had a very rapid transition from having very little to help protect infants from RSV and a very limited utilization of a monoclonal antibody called palivizumab, to now the opportunity to have universal coverage to prevent severe lower respiratory tract infection due to RSV. All of this has happened within the last couple of months. There are a number of significant implementation issues. Now we even have some supply issues that were not thought to be likely to be a problem. But I want to start off by giving you some information about the 2 approaches that are now available to modify the risk for serious RSV infection in infants. And then I want to thank the OPH immunization team for coming on to then talk about some of the implementation issues. Then we'll open this for Q&A. I also have Dr. John Bancheri on the line, who is Chief of Pediatric Infectious Diseases at LSU in Shreveport, who can also help answer questions in the Q&A. So with that, let's go ahead and get started. So you've already heard my disclosures. So the goal for my part of this discussion is to make you aware of the ACIP and American Academy of Pediatrics recommendations for the use of nirsevimab and RSV vaccine in pregnant women for the prevention of serious lower respiratory tract RSV disease in infants. As you all are aware, RSV is a very significant pathogen for children under 12 months of age. Most common reason that children under a year of age are admitted to the hospital, 1 to 2% are admitted. And if you look at infants less than 3 months of age, it's actually 2 to 3%. The risk decreases as infants get older, but there's still a significant risk out to age 5. And we also know that prematurity and certain chronic diseases increase that hospitalization risk. Overall, almost 80% of infants who are hospitalized with RSV have no underlying medical conditions. They're otherwise healthy. So the first medication that became available to us through recommendation in August by the ACIP, and that's nirsevimab, otherwise trade name is Beyfortus. This is a long-acting monoclonal antibody, so it provides passive immunity, but the real benefit of this is that a single injection will provide somewhere between 150 to 160 days of protection against severe lower respiratory tract disease due to RSV. And just to briefly show you the results of clinical trials, for infants who are 35 weeks gestation or older, a single dose of nirsevimab prevents 79% of medically attended RSV-associated lower respiratory tract infections, 80.6% reduction in hospitalization rates, and a 90% reduction in admissions to the ICU. The adverse events associated with nirsevimab were very similar in the treatment group to the placebo group. So this is a well-tolerated monoclonal antibody. A number of studies have also been done in preterms, in infants with chronic lung disease of prematurity and congenital heart disease who are currently recommended to receive palivizumab, and it turns out that nirsevimab is non-inferior to palivizumab in terms of its effectiveness against serious RSV infection. And this is data from the ACIP looking at an economic analysis. For every 17 patients you treat with nirsevimab, you'll prevent 1 outpatient visit. 48 patients will being treated to prevent a single emergency department visit, and 128 doses will prevent an inpatient hospitalization. You can see even a significant reduction in ICU admission, total of inpatient days, and ICU days. So this should have a remarkable impact on the number of children that we need to hospitalize each year for RSV. As I indicated, it's well tolerated. The most common side effect is a rash, generally pretty mild, and local injection site reactions. And if you look at the infants greater than 34 weeks in their first season, the reaction rate, as I indicated, is similar to placebo. And then for high-risk infants in their first, and then those who require a dose for their second RSV season, it has similar safety profile. So the recommendations by ACIP and the American Academy of Pediatrics are as follows. All infants younger than 8 months of age, born during or entering their first RSV season, should receive a single dose of nirsevimab. And then those patients who are 8 through 19 months of age, who are at increase for severe RSV disease and entering their second RSV season, would also get a single dose. The patients who should get the second dose are basically the same as the ones who received this, who are scheduled to receive a second dose of palivizumab because of their underlying conditions, with one exception. And as you are all well aware, I won't go through the individual things, but this is a list of those children that require a second dose of nirsevimab. They're the ones who required a second dose of palivizumab. And the one difference is that American Indian Alaska Native children have also been added because we now have data that shows that they have a remarkable increase in risk for hospitalization during their second year of life. So this is what it looks like. Child who's in your practice who is less than 8 months at the start of the season, or they're 8 to 19 months high risk, they should get nirsevimab shortly before the season or any time during the season. This year, obviously, we haven't had time to get the drug out to everybody, and therefore we're not going to be able to achieve the best control of RSV because this is obviously a transition year. If the patient is born during the RSV season, the medication should be given during the first week of life. And this means it should be given in the nursery for discharge or within the outpatient setting within 1 week from birth. And this is another implementation issue that is still being worked out. In terms of when we should give this medication, as you know, prior to COVID, RSV had a very predictable season starting in mid to late October. And as you can see from this slide, the blue lines represent 2017 all the way through 2020. And you can see that we had similar onset within a few weeks and a similar offset of RSV disease. With COVID, obviously things changed, and we've had 2 summers of RSV disease, but I think we're now getting closer to the natural RSV cycle, and we're beginning to see significant cases of RSV now up in the Shreveport area. You may be as well in your areas of Louisiana, and so the recommendation is that if you're in Louisiana, we want this drug, this monoclonal antibody, to be used beginning the 1st of October and given through March 31st, which is the usual end of the RSV season. Obviously, we need to be flexible. There may be years where RSV may start earlier, and certainly in some regions of the state. And so this dosing recommendation will be potentially modified by the health department based on local activity. But in general, if we start the 1st of October, we will cover the majority of babies that are at risk before they get exposed or infected with RSV. And then this slide, this is just from the CDC's National Respiratory and Enteric Virus Surveillance System, and this is the South, the region of the South, and you can see in the lower right-hand corner, the number of antigen detections and PCR detections for RSV have increased pretty significantly. So we're definitely at the beginning of our next RSV season. So the formulations of nirsevimab, it comes in a single dose, packaged in pre-filled syringes of either 50 milligrams, which is given to children, infants less than 5 kilograms, and 100 milligram pre-filled syringe for those infants and young children who weigh 5 and greater kilograms. For children in their second year, they would receive 2 100 milligram injections at separate sites. So many of you have heard that Pfizer yesterday made known to us that they're running out of the 100 milligram injections. Their plan is to try and fulfill the orders that they have, but they're not sure whether there will be additional 100 milligram injections for the rest of the season once that supply is gone. So palivizumab is still going to be important this year, and as long as we don't have enough nirsevimab, those infants for whom the AAP guidelines recommend palivizumab for first year and second year. If nirsevimab is not available, they should continue to receive palivizumab. And if they get palivizumab and then nirsevimab becomes available, they can switch to nirsevimab 1 month after the last palivizumab dose. And then once nirsevimab is given, no further doses are needed. Ultimately, palivizumab will not be needed because nirsevimab will replace this for all children who will get treated against RSV. So the other thing that happened in the last month and a half is that, as you know, an RSV vaccine had been approved for adults 60 years and older for use this RSV season. At the recent ACIP meeting, after the FDA expanded the licensure to include pregnant women, made a decision to recommend a single dose of RSV vaccine somewhere between 32 to 30 weeks gestation of pregnancy, and that would be given through the season that would result in a baby being born in or before the RSV season to allow protection throughout the RSV season. So pregnant women will be receiving this vaccine from September through January, again with flexibility regarding the start and stop of the season. And the reason that September to January was picked is that, again, most infants will be born during the RSV season. This is expected to provide 150 days of protection, just like nirsevimab. Can be given to pregnant women with all other indicated vaccines. And we won't know until a couple of years of using both of these approaches which of these will be better suited for the prevention of severe lower respiratory tract infection in children. So both are currently recommended. However, if a mother receives vaccine, it changes our use of nirsevimab. So this is the data on a phase 3 clinical trial for using the RSV vaccine in pregnant women. The original trial looked at women who were 24 to 36 weeks gestation. You could see significant protection against RSV-associated lower respiratory tract infection, 81.8% for the first 90 days after birth, and down to 69.4% for the entire 180 days. If we just looked at the 32 to 36 week gestation group, 91.1% efficacy after up to 90 days, and 76.5% for out to 180 days. And the reason that ACIP voted to use the 32 to 36 week designation is that in the entire group of 24 to 36 week gestation women, there was a small but significant increase in premature deliveries at at least one site, and to be safe, to reduce that risk, going to 32 weeks had a different outcome with a much lower difference. So, so that's why 32 to 36 weeks was chosen. So the advantage of maternal vaccine is that protection is immediately present after birth, and it avoids an injection of the infant. The disadvantages, for every woman, we're not sure that there's an adequate antibody transfer through the placenta. I already mentioned the potential for premature births. It was 5.7% versus 4.7% for the entire group compared to placebo for the 24 to 36 week gestation. That dropped to 42 versus 4.2 to 3.7. For the 32 to 36 week gestation group. It is possible that nirsevimab may provide longer protection, so that's something we will determine over time. It takes approximately 14 days following maternal vaccination to get enough of an antibody response to get antibody across the placenta in high enough concentration to protect the infant. So this is really important, that not only do we know if a mother has had RSV vaccine, but to know whether she's had it 14 or more days before delivery to indicate that there's a high likelihood that maternal antibody has crossed in high enough concentration to protect the infant. So with the licensure of the RSV vaccine, the nirsevimab recommendations are already modified. And so any infant aged less than 8 months born during or entering their first RSV season will get nirsevimab if the mother did not receive RSV vaccine, or we don't know the status of her vaccination, and the infant is born within 14 days of maternal vaccination, and those would be the children that will receive nirsevimab. And I'm assuming that that's going to be a significant majority this year. Initially, the AAP had recommended that if a child had a prior RSV infection that year, they should not get nirsevimab. The recommendation has now changed, that it's the same for infants who have had a prior RSV infection if they meet the other two criteria that I mentioned. And then I already mentioned what that we're not clear on exactly how well the maternal vaccine will work as compared to nirsevimab. So if you have a child that is at high risk for RSV in these rare circumstances that are listed here, the maternal immunocompromising condition, condition which may potentially reduce transplacental antibody transport, and an infant who has substantial risk for severe RSV, you may want to give a dose of nirsevimab even if the mother has gotten RSV vaccine. And then, of course, the second season recommendation is unchanged. So for all of you practitioners, I want you to be aware that AAP has a resource page that you can get to on the web. It's through Redbook Online. It explains the products and the recommendations. It has a number of resources for you, frequently asked questions, etc. And this can be very helpful to you as you go forward. Because nirsevimab is a monoclonal antibody and not a vaccine, instead of a vaccine information statement, you will have an immunization information statement. It is available. I think Javon is going to tell us more about that in the segment from the state immunization program, but you will have that to educate your parents. And then because nirsevimab, again, is a monoclonal, if you give a single dose, if you give a dose of nirsevimab without giving vaccines, and there is an adverse event, instead of reporting it to VAERS, it needs to be reported through MedWatch, which is the FDA program for drugs and injectables for reporting adverse events. On the other hand, if you've given nirsevimab and a vaccine, and there's a reaction or an adverse event, it has to go through VAERS. So just keep that in mind, that there are two different ways to report depending on whether a vaccine is given along with nirsevimab. With that, I will stop and turn the chair over to Javon. Thank you for your attention.
Thank you so much, Dr. Bocchini. I will say there's one question in the chat while Javon gets her screen up. Jose Perez was asking, NICU weight or gestation age limitation when giving the first dose?
I'm sorry, I didn't quite get the question.
Should you look at NICU weight or gestational age for the limitation as to when to give the first dose?
It's chronologic age.
Thank you. And just a note, Julia put links to all of those resources in the chat for reference. Thanks, Javon. You're
Hello, my name is Javon Davis Charles, and I am representing the immunization program. And we also have no disclosures or relationships. See if I can get this thing moving. There we are. Just have to fix my bar. Okay, there we go. Okay, so today the immunization program is going to talk first about nirsevimab availability, the Vaccines for Children's program, special considerations for RSV, and the link system. And then at the end, there'll be some time to ask questions. So you all may be aware that there has been some availability issues with nirsevimab. There has been a very robust push from national to statewide to get Beyfortus out to birthing facilities and pediatricians, and this has caused a bit of a backlog, and it seems like it's both on the private and public section. So we had to pause VFC ordering for Beyfortus temporarily until we can get new stocks replenished. So we were actually notified just this morning that supply channels are opening up again. So for those of you who order both VFC and commercially, if you do have something on back order, you may be getting it, you may not get it. We don't have very good visibility on what's available in the private sector, but I did just want to give that update that it does look like the supplies are opening up again. We are waiting to hear what our new allocations will be for Louisiana. It won't be open ordering anymore, I guess, until the supply chain issues are resolved. So we're just waiting for a time frame to know when we will have more stock available for reorder for VFC. And we will send out something through our usual channels, which is the LA immunization web newsletter or alert system that we send out through Constant Contact for our partner providers. So now I'll talk a little bit about the VFC program. Many of you may already be enrolled in VFC. We have a lot of pediatricians in VFC, which we are very grateful for. But for those of you who may not be, it's a federally funded program that provides vaccines at no cost to children who may not be able to pay. The vaccine is available at no cost to public and private providers for children who are eligible. And it's a very critical program for ensuring that children have a better chance of getting their vaccines on schedule. So eligibility for VFC are children ages 18 and under, those who are Medicaid eligible, uninsured or underinsured. It says uninsured twice, but it's uninsured or underinsured, American Indian or Alaskan Native, those who, so the key thing about children, and this is really because we are pushing this mainly to, not mainly, but we've been pushing this a lot to birthing facilities who don't always deal with insurance eligibility for newborns. So pediatricians, by the time that they come to you, they may or may not have insurance statuses that are known. You know, you may not, the baby may not have been enrolled in any particular program from the mom or for VFC. But the key thing is that the insurance status of infants must be documented separately from the parent to know whether they're eligible for VFC. So if a mother is Medicaid eligible, the kid is probably VFC eligible, but we don't want to say that that's definitely the case, and vice versa. If the mom is privately insured, we don't always know if the infant will be privately insured. So we do recommend that whatever current protocols or processes that you all have to kind of make the best determination for that, so please do so, because we do have to give VFC vaccine to kids that we have done an eligibility screening for. And all newborns should be screened for eligibility if they're going to be carrying VFC vaccines. We also had a special consideration from CDC for birthing facilities. Typically, all VFC all VFC eligible programs of facilities, they must carry all ACIP recommended vaccines. Before birthing facilities, since they usually only see newborns just for a couple of days, there is a special consideration that they can only carry nirsevimab and birth dose Hep B, and they don't have to carry all of the ACIP recommended vaccines. But we do recommend that, you know, always to carry as many vaccines just in case a kid is in NICU or is going to be there for a while, that they may be additional vaccines that baby may need. So we always recommend to carry as much as possible. So some of what we've done to encourage birthing facilities to be VFC participants, we did a webinar with them on October 10th just to talk to them about the VFC program, about nirsevimab and RSV, and encourage them to become enrolled. Currently, 27% of our facilities in Louisiana are enrolled in the VFC program, which is 14 out of 52. And our goal is really to have them co-administer nirsevimab with the hepatitis B birth dose. So many birthing facilities are very familiar and do pretty good jobs with giving that birth dose Hep B vaccine. So we really kind of want, you know, during RSV season for them to also give the nirsevimab and co-administer at the same time. So some other, this thing is all over the place. I'm sorry. Okay. Some other VFC considerations. Louisiana currently has a no borrowing policy, which restricts the sharing of VFC and private stock vaccines. So I know that there has been a lot of talk around this because CDC has waived that restriction nationally, where they are okay with sharing of private and VFC vaccine, but jurisdictionally, which supersedes CDC policy in Louisiana, we do have a no borrowing policy. So this is something that we can reconsider and see if we can, you know, whatever we can do for our processes to see if we can make it easier. But as of now, our policy is still no borrowing, and we, you know, we can see whether what we make can work out to kind of be able to maybe change that in the future. But I just wanted to, you know, let you all know that we are no borrowing as far as today and in the near future. And if that changes, we will definitely release something to let everyone know that it is now allowable. So we already mentioned about screening infants for eligibility, and that is very important. And another thing I wanted to mention that we got some questions about was the pregnancy dose and whether the mom can be searched just to see when exactly they got the RSV vaccine, or if they got the RSV vaccine, and whether it's within the 32 and 36 weeks. So if the mother did get it, it should be in links. So it may be something that you can look up to see exactly when they received it, and, you know, maybe calculate whether that would be within the time frame. So it may be another resource or two just to kind of help you all with calculating that out and figuring that out. In our VFC contact is our VFC program manager, Adrienne Mercadal-Whitney, and I included her information here. She is the best source of information for any VFC eligibility question, VFC ordering question. She is the best resource, so please reach out to Adrienne with any questions, concerns, problems that you all may have around the VFC program. So now I'm going to shift just to talk about links a little bit. So for those who have been able to order, or hopefully will be able to order soon, I'll just walk you through a few steps. I'm sorry, my screen is all over the place. I have to go back one. Okay, so to order Beyfortus, so if you are in the links section, you go to the section at the bottom that says orders, transfers. It is on the left-hand side, and there is an option to click create view orders. Once you click the create view orders screen in the bottom right-hand corner, it will take you to the following page. So this page is very important. It's called our reconciliation screen or reconcile inventory, as you see. But what this actually is for providers to actually match what they have on hand to what it's showing that they have in links. So we always need for our VFC vaccine for inventory to be reconciled and to match, what you have on hand versus what you see in links. If you have 0 on hand, you will click that 0. You will put 0 in the box for quality on hand, and then you will click submit monthly inventory. Oh, wait, I have to step back. So you have to click this box that says inactive first. So if it's 0, click the inactive box, and then you can go ahead and click submit monthly inventory, which is highlighted in yellow. So the next thing to do while ordering is just to confirm the organization, facility, address, and contact information. Confirm or click that the order set is selected as private VFC provider order form distributor. So where that part is, as I said, is the part that says order set. That's the one that you'll change to make sure it says private VFC provider order form distributor. So under the order details section, select the RSV vaccine, enter the number of doses under the order quantity, but like I said, they may have to be adjusted just because we have a limited supply right now. You select the product that you want, the 0.5, the 100 milligrams or the 50 milligrams, any comments that you have, and then submit the order. And I just wanted to add, so far we have about 5,000 doses that have been ordered post FDA approval and about 185 that have been administered so far. And that is it for the immunization program. And we will also pause for any questions.
Thanks so much, Javon. And I don't see any questions in the chat currently, but those who are participating, you do have the ability to come off of mute and ask a question if you'd like to do that, or certainly feel free to put those questions in the chat box.
While we're waiting, I just want to mention that Javon had sent us the CPT codes for Lucidomab and the administration fee code of the AAP, and has worked to develop a new code that really represents not only the administration of the monoclonal antibody, but also the counseling of the parents. And so that provides a higher reimbursement than would be just for an injection. And so I think that's a really good plus that AAP has worked on with CDC to make happen. And so that is available to you all. For consent, Rachel, I think that I would do what you do for other vaccines. If you have people sign, that's fine. If you have people agree, and then you verbally, and then you put it in the chart, it's whichever way you routinely do the vaccines that you normally give. And I think that would be adequate. Javon, do you have any thoughts about that?
Hey, no, I would say the same.
I'm dropping all of the resources that I shared throughout back in the chat so that you can see them all at one place.
Are there any other questions or challenges or requests while we have our experts on the line today? I'm here to open that dialogue.
We might also give Dr. Vancheri a chance if he's got any other comments to add. He's been very calmly, quietly sitting there.
Yeah, I'm my typical calm, quiet self. I think that the experience of anybody who's already given a few doses may be helpful, and really it's right now the logistics questions of getting more doses out and available are the big deal. So, Javon, question I had for you is, of the 5,000 doses that have been ordered, how many doses have actually been sent out to practices so far, or hospitals?
Dr. Vancheri, this is Quan.
Hey, Quan. Yeah, good.
Yeah, as of yesterday, of the providers that ordered the vaccine, approximately, again, as of yesterday, around a little bit over 6,000 doses have been shipped out to those providers. And of those, about a little bit above 200 doses were administered.
Okay. And are most of those in clinics or hospitals, or sort of what's the breakdown, or do you know?
Don't know the breakdown offhand, but the facility, not counting the parish health unit, it's around about 115, I think, or 19 facility around the state.
Okay, so that'd be mostly clinics, it seems.
Yes. Mm-hmm.
Great.
I think I saw a couple of hospitals, but yeah, for the most part, it's clinic.
And then we do have a question in the chat box from Gregory Fulton about any recommendations on doing vaccine in nursery or NICU. Clearly, if the baby is vaccinated before they leave the hospital, then they don't go home and be at immediate risk for exposure to RSV. So that would certainly be a preferred way to get the vaccine to the baby. As you heard, not all hospitals are VFC providers, and because of the DRG for birth, some hospitals have not taken on the cost of adding this to the every newborn discharge. That's an ongoing issue that we all need to try to address. So I would certainly speak with your institution. Certainly, babies in the NICU who were at high risk and met the criteria for palivizumab, we certainly would want them to be vaccinated if at all possible, but it would be better if everybody gets vaccinated. I don't know in the Medicaid system the percentage of children who leave the hospital who come back for that first visit within the first week of life, and that just delays the administration if they don't get it in the hospital, and puts them at increased risk for acquiring RSV. And as we mentioned, in that first month of life would be the highest risk for hospitalization. So I think we have a lot of work still left to do. You can talk to the hospitals you work in and see where they stand on this. And actually AAP is trying to work to increase the DRG payment to match what the cost of nirsevimab would be, so that hospitals could absorb it without taking loss. So more to come on that, but if you can get people to give it, I would, in the hospital before they go at home, I would certainly do that. But like I said, I think there's going to be some time before we iron that out for most babies. How soon after infection can a baby be vaccinated? Yeah, the latest statement is after they've recovered completely from the RSV infection, they can receive the vaccine or the monoclonal antibody.
Okay, so just like no fever and not feeling so bad respiratory wise?
You know, they're going to have some protection, Natalie, that will keep them from being at significant risk for some period of time. So I don't think it's urgent. I would wait until you're satisfied that they have resolved their symptoms. If they're wheezing, let them get over it. You know, give them time to recover. So if you wait an extra week or a couple of weeks, I don't see that that's a problem. You know, the risk, I was just to say, the risk of a second infection in the same RSV season is real. It's less than 0.5% of babies. So, so it's not a high risk, but it's an important one, and that's what why CDC went ahead and made that recommendation.
Okay, because I had one yesterday and he was still kind of sick, but his 6-month visit's in 2 weeks, so I just decided to wait. But I had another one last week who the kid was slightly snotty. I did a respiratory panel that we sent off and gave him the vaccine, and he ended up, he had RSV. But then he came back for as well, and he was fine, so.
Okay. All right. I think, again, if you know they have RSV, I would just wait until their symptoms have completely resolved.
Dr. Bocchini, there was one other question in the chat. Does the nirsevimab have a side effect of fever, or are there any other side effects that have been seen?
The only difference between the nirsevimab and placebo groups was the local swelling pain, the typical thing with an injection, and the presence of a rash. No significant febrile response compared to placebo. And again, if I didn't say this, you can certainly give nirsevimab with any other vaccine that is needed for that child when they come to your office if you're looking at the less than 8-month-olds.
Well, thank you to everybody again. It looks like our chat is clear. I do believe Julia shared in the chat a link to claim your CME credit. As a reminder, we will be sending out to everybody who participated on today's call a copy of the slides, the resources, and the link to claim your CME credit. Julia, is there any other announcements we need to make before we close?
Yes. Make sure you take your evaluation to help us continue to improve our education and claim your credit. I have dropped the link into the chat, but it's laap.kiteform.com/RSV update. And that QR code goes directly to the evaluation. Next week, please join us or consider joining us for Stop, Look, and Listen, How to Pinpoint Medical Child Abuse with Dr. Paige Culotta. She will be helping us to learn to identify patterns in medical child abuse, explore characteristics that may contribute to an early diagnosis of medical child abuse victims, and plan multidisciplinary evaluation for patients with concerns of medical child abuse. And that will be Thursday, the 26th at noon. And then finally, our next big conference will be August 16th through 18th for the Senla Potpourri in Alexandria, Louisiana. So please go ahead and get that on your calendar for next August.